Welcome to the AWE session on endohepatology. We're very excited to have Dr. Ken Cheng here today to demonstrate EUS guided liver biopsy, PPG. Welcome, Dr. Cheng.
Thanks, Phoenix. So I'd like to walk us all through a number of now emerging techniques within the space of endohepatology. So I call your attention to the exquisite imaging. I'm using the Aplio i800 processor and the UC180T echo endoscope. So we're looking at the porcine liver. Obviously, it's a non-circulating model. So the first maneuver I want to show you is EUS liver palpation. It's a way to assess the stiffness of the liver, and our studies show that it can be predictive of advanced liver disease, fibrosis, and cirrhosis. So the technique involves going to the left lobe of the liver and then indenting with the big knob up as much as possible, and then freezing the image, and then drawing two parallel lines. The first line, as you see on the screen, is at the top of the indentation. The second parallel line is going to be at the deepest point of indentation, which is here. So that line is going to be here. And then we have a third line which measures the distance between those two parallel lines. And so that distance from here to here. So three lines, two parallel, and one is looking at the distance between the two. And here we see the distance is 5.3 millimeters. Our studies have shown that if it's 4.5 millimeters or greater, very high chance of it being not fibrotic. If it's less than 3.5, very high chance of stage 3 or 4 fibrosis. So this is a very quick and easy, low-tech way of getting assessment of liver fibrosis and cirrhosis.
That seems very objective. Do you also have a feel, like how much resistance you have as you elevate and
No, you
press?
don't really get the tactile feedback, Phoenix, but it's almost a visual feel, if that makes sense. So next, I wanted to show you shear wave elastography. We're all familiar with FibroScan, which looks at the stiffness of the liver. That is transient elastography without any imaging. Then we have one-dimensional shear wave elastography where you have imaging. There's a push pulse, and the push pulse sends a perpendicular wave in the liver, and the speed of that wave determines the stiffness of the liver. So that's one-dimensional shear wave. And now with the Aplio system, we have 2D shear wave, two-dimensional shear wave, and I'll show you that in a minute. So here we send out multiple push pulses at the same time at different depths, and look at the propagation of that wave across multiple levels, and we're able to much more accurately assess the stiffness of the liver parenchyma. So on the Aplio system, what we're going to do is we're going to hit the shear wave button, and then there's a button called one shot, which will give us the shear wave mapping. So here, what we see on the left is the propagation wave of the speed of the push pulse generating perpendicular waves on the liver, and you can see a very nice wave pattern. And on the right is called measurement assessment MAD. Measurement area detection. I remember MAD, but measurement area detection on the right. So the measurement area detection can be calibrated. So I am going to reduce the number of boxes so that I can be much more specific in picking the region of interest. So for the region of interest, I have this box. And what I'm doing on the left screen I want to put the region of interest where the waves are nicely propagated. I don't want to put it down here where there may be some disruption of the wave. These waves look very nice and parallel and undisrupted. And on the MAD on the right, I'm just going to put it where there's a cluster of those little boxes. So for my first measurement, I'm going to choose that spot right there, and I'm going to hit set. And then for my next box, I'm going to pick an area right about here, and I'm going to hit set. So I've picked 2 points where I'm measuring shear wave, and I'm getting 17.8 and 22.7. And so I've gotten 2 great measurements just in one freeze and 2 button clicks. So instead of doing 10 shear wave measurements, which is with what we do with 1D, now we just do 5 measurements, each one with 2 regions of interest, a higher accuracy and more efficiency. So later on, I can show you the report that's generated, combining this with also the ATI. So maybe now I'll show you ATI.
So the 2 regions of interest is left lobe, right lobe, or do you?
Right, so typically we'll do shear wave of both right and left lobe because there could be some variability. And then we'll do shear wave of the spleen because stiffness of the spleen correlates very highly with portal hypertension. So then in the past, we had no way of quantifying the amount of fat in the liver, steatosis. We looked at imaging semi-qualitatively, but now with the software, we can measure fat attenuation. We call this ATI. And so I'm going to show you ATI. I'm going to hit the ATI button. Okay, so then we're going to move the ATI mapping so that we get as much filling. And the blackout areas means we're lacking some information, so this is not a good place to measure. Maybe, let's see, we want a nice place. And I'm going to lower the region of interest a little bit.
You taught us the different segments of the liver. Does that play a role into imaging when you're doing assessment on shear wave?
Yeah, I think it's important to understand the liver anatomy and the segments. Let me see here. I'm trying to get a better... it's a little bit different in the...
It's different in the
dead
pig
yes. model. Okay, so here we're getting 0.69 decibels per centimeters per megahertz. So this patient is borderline steatosis, and we would do 10 measurements and put it into our final report. So with that, let me show you the final report.
About how much time does it take to do these measurements?
Just a few minutes, actually.
So it's quick.
Really quite quick. I want to hit enter. Yep. Okay. So this is our report. You can see, first of all, on the shear wave, we have the average standard deviation of the stiffness value. And then just below that, we have our attenuation value. So it'll give you all of those values in a very nice consolidated report. So this has been a game changer for the diagnostic assessment of liver through endohepatology.
Does this information help you during the procedure, or is mostly a post-procedure assessment in terms of what you do next?
Yeah, so both. So these numbers are very important to give back to our hepatologist. But as we're doing the procedure, say we're considering liver biopsy to assess for fibrosis, but we do shear wave and it's normal, and we do ATI and it's normal. maybe we don't need the invasiveness of a liver biopsy because that is likely going to be normal as well. So then we develop a clinical algorithm based on the non-invasive measurements first. And on the flip side, if we're not sure and the shear wave is high and the ATI is high and we want to confirm that with a liver biopsy, then we proceed on, as well as with EUS portal pressure gradient measurement. Doing these non-invasive measurements first can help inform whether we do the more invasive or not.
Very nice.
All right, so then the next thing we want to show you is EUS PPG. So with EUS PPG, we identify the hepatic vein and we identify the portal veins. So the hepatic veins leave the liver, the portal vein enters the liver. We use the Cook EchoTip Insight 25 gauge needle device, advance that under EUS into each of those vessels, and then we measure 3 times and take the average of the 3 and then subtract the difference, and that gives us the gradient. So for sake of time, I'm just going to show you the technique with one vessel. Here we see the portal vein. Obviously there's no blood flow, but we will show you the technique of the needle insertion. So this is a 25 gauge special design needle that has been FDA approved for portal pressure measurement in humans. We will advance the sheath a little bit here. You can see the sheath there. Tighten that. And then just like an FNA needle, there's a safety, and the needle tip is there. So we're going to simply target the vessel. And so I usually like to do a quick stabbing motion like this. And that got us almost into the vessel. And then I'm going to now enter the vessel. And now we should be in the vessel. Yeah, we're in the vessel. And now I'm going to pull back until I confirm that the tip of the needle is in the middle of the vessel, which should be pretty soon here. That looks pretty good to me. And so at this point, you have a good needle placement. And now we're going to flush. Monica's going to just flush and clear the tip. That's perfect. And then she's going to read out the measurement. So we have a needle device, we have a non-compressible tubing, and we have a pressure gauge. So what is the pressure now? 14, 12, 11, 10, 8, 8. Oh, 8, perfect. So typically what happens is when she flushes the tip just a half a ml, you'll get a rise in pressure just from the clearance of the fluid inside the needle. But then everything equilibrates, and the pressure that's felt at the tip of the needle is translated all the way to the pressure gauge, and then that pressure is stabilized, and here it's stabilizing at 8 millimeters of mercury. So then we would flush again, and we would see a rise.
Flush.
Yep, did the pressure go up?
Yep.
Okay, so 20, went up to 20, and now it's
19,
settling down. So it takes about 20, 30 seconds for it to equilibrate. And what's the number now? 15, 14, 13,
12,
12,
11,
11,
10,
10,
10,
10,
10.
10. Okay, so the first number is 8,
8.
second number is 10. So then we'll take a third measurement and say it's 9. So we'd have 8, 9, 10, and then we take the average, which is 9, and that'll be the portal vein pressure. We would do the same thing on the hepatic vein side and then calculate the gradient. So that is how we do EUS portal pressure gradient measurement. It's a very straightforward procedure. The important aspects to consider in the technique is you you try to always have the needle traverse through some liver parenchyma before entering into the vessel. You try not to hit the portal vein through the duodenum without any liver, because the liver will be your friend to tamponade your puncture site into the vessel. So here, for example, the needle is now going to come back, and when it comes back, there's no issue of bleeding because that liver is immediately tamponading the puncture in the wall of the vessel. So now I just need to back the needle further into the liver parenchyma, and because it's a 25 gauge needle, bleeding is very, very rare. At this point, we would put on the E-flow to confirm there's no flow in the needle track. And once that's confirmed, we simply remove the needle, and then that part of the procedure is completed. So now we're going to show you liver biopsy.
Are these patients intubated in a lateral left, lazy left? How do you prefer their position?
So in general, we have them supine. Supine or lazy left, but supine is preferred. That way the pressure gauge can be placed at the level of the right atrium as your baseline. And they are either under max sedation or general. Moderate sedation can be a little bit tricky because the patient may move. And especially for liver biopsy, you don't want patients to be moving during the procedure. So now we're going to EUS guided liver biopsy, and we want to find a nice segment of liver that we can pass the needle with a long throw. So let's see here.
Their recovery is the same as any other endoscopy from liver biopsy?
Yeah, when we first started, we used to, recover longer or stay overnight, but we stopped that early on. We realized that because of the ability to watch for hemostasis before even removing the needle, once the patient is awake, if they're not having any pain, they can be discharged. So, okay, this is a reasonable segment of liver. I'm using the Cook clear core needle. They come in 22 gauge and 19 gauge. We're going to demonstrate the 22 gauge needle today. So this is a core biopsy needle. And so here we're going to advance the needle, the sheath, just out a little bit and tighten that. And we're going to first confirm with E-flow that there's no flow, but obviously there will be no flow in this pig part. And then we want to measure to see the amount of liver in front of us. So we've got about 4 centimeters of liver. So I know how far I'm going to throw my needle. So I'm going to demonstrate for you what we call the dynamic suction technique. We're going to put on a 10 cc syringe with a 3-way stopcock. The stopcock is locked. It is set to the highest pressure, which is 8 centimeters of the syringe pulled back. So the suction is ready, but we're not going to apply suction at this point. We're going to first advance the needle into the liver parenchyma. So I'm just going to do that. So we do want to advance the needle in slightly into the liver. And then I'm going to set my safety about 3 centimeters. So now we have the safety set for the distance of the throw. We have the needle well in sight. We know the trajectory of the needle. And so at this point, we're going to actuate the needle as fast as possible. And it's not really, you don't have to watch it anymore, you just throw it. And just before I throw it, Mana's going to turn on the suction because the suction will help with the specimen come into the needle. But as soon as I finish my actuation, Monica will turn off the suction. We don't need suction when we pull the needle back. That'll just suck a bunch of blood in and fill up the needle. So here we go. 1, 2, 3, suction on. Boom, suction off. So that's actuation 1. Then we're going to leave the suction off as I pull back. No need to suck all that blood up into the needle. So now the needle is going to come back. And then we're going to do a little bit of a fanning technique. We're going to change the direction just slightly like that. And everything is stable. My guard is in good position. So I'm ready for my second actuation. Monica, suction on. Boom, suction off. So it's a very brisk shoulder, elbow, wrist motion. And then getting ready for pickleball.
Yes.
Okay.
Do you have E-flow turned on as you pull back?
Okay.
And what are your techniques when you see a little bit of bleeding or?
So then suction on.
On.
Off. So typically I'll take 3 actuations. If there's some fibrosis or cirrhosis, I'll take 4 or 5. On.
On.
Off.
Off.
So that's 4 throws. So at this point, we're going to turn on E-flow to make sure that we don't have. As a matter of fact, we're going to turn on SMI, which is kind of E-flow on steroids. It gives us even better sensitivity in the low flow. Let me see. Yeah. So obviously there's no flow right now, but this gives us micro flow, which is great for hemangiomas and all that. So there's no flow obviously in the needle tract. If we see flow in the needle tract, the main strategy is don't pull the needle out, because if you pull the needle out, then it's a bleed, right? So you keep the needle in and you wait 1 minute, 2 minutes, 3 minutes, and most of the time the flow will stop. That means you've clotted the needle tract and you can safely remove the needle. If, however, at that point there's still flow, then there's a few maneuvers you can use. You can slowly pull the needle back in a zigzag fashion. You can take your sheath and advance the sheath to put some tamponade at the puncture site. And finally, you can use what we call the EUS blood patch delivery, where you simply take the stylet, put it back in the needle, advance it about 1/3 or halfway back into the needle. That takes the blood clot at the distal tip of the needle that's already clotted, and it delivers that into your needle tract, and it's a blood patch. It stops the flow. So those are the 3 techniques. And if you really need to, you can inject gel foam. All right, so we're going to take the needle out. You can see how exquisite the SMI is in this case. And that, I think, concludes. Yeah.
In the short 1 minute we have left, can you go over the indication for everything that we've done in this segment? What kind of patient would you see for this procedure?
Yeah, so there are 2 main reasons to do endohepatology. One is to assess the etiology of the liver disease. Is this seronegative autoimmune hepatitis? Is this overlap hepatitis? Is this fatty liver on top of PSC or PBC? The diagnosis is uncertain. So endohepatology is critical in getting good, high quality specimen, 20 plus, complete portal tracts, safely done, and sampling both right and left lobe of the liver. The second main indication is not so much what is the etiology, but how advanced is the liver disease. Are we talking about early fibrosis? Are we looking at, stage F3, F4 cirrhosis? Or is the patient on the verge of decompensating? We want to know that. And that's where we leverage liver biopsy, shear wave, portal pressure to look at the extent of the severity of the liver disease. And one of the sweet spots in PPG is when it's elevated between 6 and 10. It's not yet clinically evident. There's no varices, no portal hypertensive gastropathy, but patients already have portal hypertension. And in patients with fatty liver related disease, that is the sweet spot for interventions such as endobariatrics. And studies have shown that you can actually reduce their portal pressure and completely change the trajectory of their liver disease and their overall survival and prognosis. So those are the two main values of EUS PPG. Sometimes it's both, right? Sometimes the etiology is uncertain and the severity is uncertain. And it's also really a one-stop shop.
Yes.
You have your endoscopy,
Yes.
you look for varices, and you have your imaging. You can find focal liver disease. You can do biopsy. You can do shear wave. You can do fat attenuation. You can palpate the liver. So really, one procedure. I can't think of anything else that you would need to know in that patient with liver disease. So that's the real strength, is the one-stop shop.
That's beautifully done. Well done. Thank you very much.